Hi, welcome to this short narrated lecture on outcome measures and the ICF. My name is Dr. Chee-Wee and I'm a lecturer in physiotherapy. For those of you on the physiotherapy program, at the end of this week, we would have looked at the different outcome measures used in clinical practice, or at least some of them that's used in the context of musculoskeletal practice. We will also be looking at some of the concepts relating to reliability and validity from a clinical perspective. And also, we'll be applying the International Classification of Function to our outcome measures that we use and to see what are the relevance and the interpretation of this for our clinical practice. So the question is, why do we need outcome measures and clinical measurements? Why do we need it in our clinical practice? Why can't we just go ahead and see our patients and sort of determine whether they have improved or not, or are they getting any better simply just by our own observations? Well, in order to answer this question, we'll firstly need to understand what can clinical measurements do and what are some characteristics of clinical measurements and outcome measures. So, what can outcome measures do? Well, outcome measures can be quite helpful in terms of helping us to be able to determine how far or how severe a patient's condition is. Now, there are two main things that we can get out of using outcome measures. Firstly, we're able to differentiate between patients at a point in time. What does this mean? It means that, let's say for example, if we're concerned about the severity of a patient's injury or a type of symptom, then by using the same outcome measure, we're able to tell whether this particular patient A, as compared to patient B, is it more severe in their symptoms or less severe. The second attribute that we can get out of using outcome measures is to be able to determine whether just that particular patient has actually improved or not improved over time. How do we do this? What we can do is simply administer the outcome measure several times within the patient's journey. So perhaps at the beginning, after a certain treatment, and perhaps some weeks later. And we'll then be able to see whether the person has actually improved over time. So outcome measures are actually particularly useful in several stages of the patient's journey. And on this slide, it actually outlines 4 time points where it could be particularly useful. So the very first encounter where we could actually use outcome measures is when the patient first comes to us. So the patient has just got referred to us and we are seeing the patient for the very first time. So the very first thing you need to determine is how severe or how serious the particular injury or the symptom is for the patient in order to decide what your treatment goals are. The second point where we could actually use outcome measures is in between treatments, where we wanted to see the particular treatments that we use have actually allowed the patient to improve, or has it not done anything for them, or perhaps they have deteriorated over the several treatment sessions. By using the outcome measures, we are then able to determine how effective our treatments are, and perhaps also to determine what are some confounding factors and influences outside that is beyond the control of our treatments. With this, we can then better support the patient in choosing what are the steps ahead in order to facilitate their rehabilitation. There's one last point where outcome measures would be particularly useful, and these time points tend to be a transition for the patient where we know that at this particular transition point, the patient should be experiencing some improvement. By using outcome measures, we are then able to benchmark and determine whether the patient has truly improved. And why do we want to do that? Well, perhaps we want to move on to the next stage of rehabilitation, where we actually increase the difficulty of the rehab that we are providing for the patient. Or perhaps the patient has reached it's at the end of the journey with you as a therapist, and therefore by using that particular outcome measure to determine whether the patients are fit for discharge. Whenever we use an outcome measure or any type of clinical measurements in our clinical practice, it would be good to not just make the outcome measures as you go along. What you want to do is use some sort of standardized outcome measure. And what I mean by that is that it's been publicized and publicly known for that particular outcome measure and commonly used by other clinicians as well. There are several advantages to the use of standardized outcome measures. Firstly, when you start to interpret any values that you get out of the outcome measure, the interpretation will be less ambiguous. With that, it means that you're able to compare between sessions, but also between patients and between clinicians as well. The next advantage of using a standardized outcome measure is that there will probably be formal documentation about the development and application and scoring of the outcome measure. And what I'm talking about here is usually mainly paper-based outcome measures, but some non-paper-based outcome measures can also have documentation of such sort. Why is it important to have that? Well, it allows standardization and the similarities in the application of how you administer the outcome measure between you and your colleagues. With this, it means that the reliability and the validity of the outcome measure that you'll be using will be maintained and enhanced. The third advantage of using a standardized outcome measure is it's usually for service evaluation purposes. Let's say, for example, someone comes along and does an audit of your notes and then sort of questions why you're using this particular outcome measure. Now, if your outcome measure that you use is fairly commonly used, then it will be much easier to defend why you have chosen that particular outcome measure to use it to evaluate the patient. Now that we've understood and appreciated the importance and the benefits of using outcome measures and standardized ones as well, it is now important to see how it then relates to our clinical practice. So what I'm going to do is to introduce you a framework called the International Classification of Function, and to link some of the domains within this framework into the outcome measures and how we actually interpret them. First of all, we'll start with the International Classification of Function, or in short, I'll call it the ICF. The ICF mainly has three domains. The first domain is called structure and function, and within this particular domain we are mainly concerned about tissues, for example your bones, your muscles, your ligaments, and any sort of tissues within your body, whether it's hard or soft. But it could also deal with function in terms of a particular system of how it actually works in the body in order for your body to work in a functional manner. The second domain is called activity capability. Within this domain, what it encompasses are the basic movements or basic abilities of what your body can do. For example, if you were to talking about the upper limb, about the shoulder, whether the shoulder can flex or extend or rotate, and therefore your upper limb is able to be raised up or down, or perhaps abducted sideways, these activities are called activity capability because it's what the person can do. Of course, it's not just limited to the upper limb, it can also be extended to any part of your body and any part of function. What I've just given you an example is how you would measure range of motion of a joint, but you could also extend it towards muscle strength, pain perception ability, sight or brain function, cognitive function, and these are just some examples where you can extend it towards. The last domain is participation capability. Within participation capability is when we add up some of these activity capability in order to be able to submit to a person's social role that they engage in. Let's take for example, using myself as an example. I would need a lot of my upper limb function in order to prepare breakfast for my children. And the reason why I prepare breakfast for my children is because I am their father. And therefore, my activity capability of using my upper limbs will contribute towards my social role as a father towards my children. However, if one day, if I was to accidentally injure both my limbs, that will severely impede my ability to make breakfast for them, and therefore my societal role as a father will be slightly diminished, and that what is meant by participation capability. It is important to note that the 3 domains of the ICF isn't just isolated on its own, and that it actually interacts with its context within the life of the person that you're considering. So let's take, for example, looking at this ICF model that's been published by the WHO. You can see that the body functions, the activities and participation are linked and connected to the person's health condition, the environmental factors that influences what the person does, as well as some of the personal factors that the person does. So when we actually consider and see someone within the clinic and looking at the 3 domains of the ICF, we need to take also their personal circumstances into context as well. For every domain of the ICF, if there was some dysfunction within that domain, you would have a negative terminology to describe dysfunction within that domain. For structure and function, we will call it the impairment. For activity capability, we'll call it activity limitation. In participation capability, if there's a dysfunction there, it will be called participation restriction. For those of you who have been dealing with the ICF for a fairly long time, you will know that the current terminology used in this version of the ICF is actually the second version. In the very first version, these 3 domains will correlate to the terminology of impairment, disability, and handicap. And because this version 2 of the ICF has superseded the version 1, therefore what we'll do is stick with the version 2 terminology. It is important to know that the domains within the ICF isn't a linear progression. That is, impairment does not necessarily lead to activity limitation and does not necessarily lead to participation restriction. What you need to understand is that these 3 domains can exist and stand alone and may not directly correlate with each other. This particular information about the non-linearity of these 3 domains within the ICF has got implications on how we use it and interpret it for our use of the outcome measures. A lot of times when physiotherapists use outcome measures, what we tend to focus on are on the impairments. For example, we are very concerned about muscle strength, we are very concerned about joint mobility, and we are very concerned about the sensation of a patient. And all of these are very important in their own respects. However, what you need to know is that when patients come to you to seek some help, they do not come just simply because their joint range of motion is inhibited or that they are weak in a certain muscle or a group of muscles. What they are really concerned about is because some sort of activity that they do, or perhaps some sort of societal role that they're engaged in their everyday life, has been impeded or restricted in some sense. These are usually the main concerns of your patients. Therefore, the implication for our outcome measures is that a lot of the outcome measures we use should be tailored to these patients' expectation about what they can achieve in terms of their activity capability and their participation capability. A lot of the outcome measures, as I said, that physios use have been designed just to simply measure impairments. But what we need to do is go on and find outcome measures that also are much more relevance to the patients themselves. And these should be measuring activity capability and participation capability. And finally, to sum up, these frameworks such as ICF are very important to help us determine how we eventually use outcome measures and clinical measurements for us to determine whether a patient has improved or to help us problem solve a particularly resistant patient's reaction to treatment. But in order for this outcome measures to have any meaning, we will then need to be able to choose and interpret some of these outcome measures in terms of their characteristics, for example, their validity, their reliability, and their responsiveness. And also we need to be able to read some of this literature and determine what are some of these target values of the outcome measures before we decide that the patient has actually improved enough to be discharged. So I'll leave you with this message that no matter which discipline you are from within physiotherapy, or perhaps you are not a physiotherapist but a healthcare professional, in many parts of your practice, even without you knowing it, you are trying to gain some sort of information from your patients to determine how well they have done in order to make the next decision in terms of what to do next or to discharge them. Therefore, what you are trying to do is find out informally what are some of these outcome measures or clinical measurements. It is perhaps wise to then be able to use certain outcome measures and clinical measurements that have been standardized, and in order for you to make a much better decision on how the patients have progressed. So I hope that this short lecture will help you understand the importance of standardized and robustly designed outcome measures and clinical measurements. Thank you very much for spending the time, and I wish you a good day.